Okay, thank you very much to Alicia and to Secura for asking me to do the presentation. And one of the reasons I think that this is important is because I know at our facility we work very closely with our histology department. We have a very close relationship there, located across the hall from us, so we're very close. We can take our special stains over there, our cell blocks over there. So we work very closely with them. We're on one cost center and we have one manager. So I think this is an important subject. In a lot of labs, histotechnologists are processing cytology, and they're also going on fine needle aspirations and helping with adequacy checks. So we'll be discussing some of that today. So some of the objectives we have today is I want to introduce you to a little bit of basic cytology principles. We're going to look at cells and talk about how we look at cells under the microscope and make decisions. And again, we're going to explore the emerging role of histotechnologists in cytology processing. And then we're going to talk about some emerging technologies in cytology and their histologic implications. At Methodist Hospital, we're a big institution, and we're kind of in the medical center, the hub. And we did have like 4 or 5 ancillary hospitals around, and now we just bought 2 more in Clear Lake, so we have 6. So what happens is the outside ancillary hospitals, a lot of times the cytology, and some of them are processed at the ancillary hospitals and sent to us, and then the histotechnologists do some of the work, cytology work, like going on assisting in radiology-guided FNAs, and then they make the smears, and then they're sent to us. So we'll talk about that today also. We also, are working very closely with histology on molecular and the prep for cell blocks, the new kind of preps for cell block called the Celliant cell block. A little bit about cytology. Cytology is, of course, the study of cells, and histology is the study of tissue. So that's how we're a little bit different in that respect. We look at the individual cells and not the way they are formed in the tissue. So our cytology was basically brought about by Dr. George Papanicolaou, and I know women who go to have their Pap smears just be glad that it got condensed to Pap smear, because you'd have to call your doctor every year and say you wanted to schedule your Papanicolaou smear. So it's good that they just shortened that to Pap smear. But anyway, he was an American of Greek descent, and he was working at Cornell University. And he was actually working on cells and how hormones influence the maturation of cells, and he noticed that he was seeing some changes in the cells, and when they got the tissue on these women, that it corresponded with tissue change. So that's how cytology was first came about. And in the 1940s, cervical cancer was the #1 killer of women in the United States, and with the entrance of the Pap smear, the death rate from cervical cancer has declined by 70% from 1955 to 1992. We still have in this country around 4,000 deaths from cervical cancer every year. A lot of that is due to women not being able to get in for the screening. I know at Methodist we do a lot of charity care. We do a lot of clinics that work with charity people, so we're trying to do something to further get that rate down. In cytology, it's different than histology. Histology, you've got to take tissue out, and that's kind of you have to deaden the area that you're going to take tissue, and it's a little bit hard for the patient. But cytology, you can do what's called exfoliative cytology, and your cells just naturally shed from your body. You can take some kind of scraper, and you could scrape your skin and put it on a slide, and you can see cells. You can also scrape the inner of your mouth and with a swab, and that's what we do a lot of times when we're checking our stainer. If we need some cells to check our stainer, you can scrape the inside of your mouth and put it on a slide and stain it. And so you can remove cells from a non-abrasive means. Some of the ways that we get exfoliative cytology is, of course, the pap smear, cervical vaginal smear. Also sputum. In your lungs, the cells exfoliate. And you can have a patient cough into fixative, and then we can look at the cells. When you void urine, you know, you have cells there. And actually you can see cells all from the renal, all the renal organs. And then body fluids, when you have an infection or cancer, sometimes your cavities build up body fluid, and the cells naturally shed from that. And so the radiologist just taps the fluid, and we'll look at some of that. And you can actually get cells from the body fluid. So you don't always have to use abrasive methods, but one of the abrasive methods that we do use, or we get cells from, is a bronchoscope, which we have a lot of transplant patients here at Methodist Hospital. So what they want to do is if a transplant patient, say, is having problems, they want to know, is it an infection or are they rejecting their transplant? So they will do a bronchoscope, and they can go all the way out to the end of the bronchus and to the it's called a BAL, and they can get all the way out to the alveolar spaces. And that's important because people who have immunosuppressed problems, sometimes they get pneumonias, and of course you're probably familiar with the GMS stain for PCP. And so when we get BALs, we always make extra cytospins, or however you do it in your lab, and it's sent for GMS. And this is how they get that particular type of specimens. And another way that they can use a scope is, of course, the endoscope, and they can go, as you can see, they can either go from the bottom up or from the top down. And you can reach areas, put saline in there and then pull it back out and send it to cytology, and we can look at cells that are picked up. And then the most aggressive thing, I guess, we do in cytology is called the fine needle aspiration biopsy, and that's really becoming very important. And the number of fine needle aspiration biopsies we go on has increased by at least, it increases about 20% every year. What happens there is through either ultrasound or CT or fluoroscopy, the radiologist images the lesion, and then they put a needle into it and bring out just a few cells, and then we can usually make a diagnosis on less than 100 cells. And this is good for the patient because they don't have to undergo surgery. They can kind of find out what is going on before surgery is done, and then that way, if they need to do chemotherapy before they do surgery, or if they need to do some other type of treatment, they can do that. And a lot of times it's just to find out, is this a malignancy or is this an infection? So you can also do superficial. If the pathologist can feel the nodule, then our pathologist can put a needle into it, and we look at the cells from that too. But most of the time it's radiology guided, and you can see this is the hub of the needle, and this is the needle, I believe this is a lung, and this is the needle going into the lesion in the lung. And they're, radiologists especially here, are very good at getting very small areas that they can get cells from for us. So in the cytology lab, we basically divide our lab up into gynecological specimens and non-gynecological specimens. And of course, the gynecological specimens are the pap smears. And there's three basic types of pap smears you can have. One is called conventional, and that's where the doctor takes the smear and just smears it onto the slide, sends it in. That's what they all used to be until about 20 years ago. They developed the thin prep and the sure path, and these are liquid-based preps, and we're going to look at some of those and some of the machines. And what these two machines do is it takes out all the blood and inflammation so that you can just see the cells that you need to see. So it's really changed, revolutionized pap screening. And then on the non-gen, we get body fluids in, we get bronchial specimens, urine, radiology-guided FNAs, anything they can suck or scrape or pull out of a patient, we get it. So we get a lot of different types of specimens. So this machine, this is called the, this is one of the liquid-based pap preparations. Over here is a conventional smear like I was telling you about, where the doctor takes the scrape and he just smears it on the slide. And what happens is, you know, if there's a lot of inflammation or a lot of blood, it would sometimes obscure the cells. So there were some parts of the slide you would not be able to visually look at. Well, and this is a picture of a liquid-based prep, and you can see that the prep, these are just, it's pure cells in here. Some of the inflammatory cells stay, and some of the infections we'll see. I'll show you what some infections look like under the microscope. And we still see that, but the blood and most of the inflammation goes through these filters, and you end up with just cells left on the filter that are deposited on the slide. So it really has revolutionized the pap smear. The other FDA-approved pap test is called the SurePath slide prep tech, and what it does is it's a density gradient that you put the sample in. The doctor takes the smear just like he would, you know, when he's doing a pap smear, and he puts it in a vial, and then it comes to the lab, and you put it in a density gradient, and what happens is the cells, you spin it down the centrifuge, the cells go to the bottom, and the blood and the inflammation stay at the top, and they are siphoned off, so you end up with a monolayer, pretty much monolayer prep that is free of blood, where you can just, and inflammation where you can just see the cells. So those are the two FDA-approved methods. When a doctor takes a pap smear, he tries to get, it's called the transformation zone or the squamo-columnar junction, and this is a picture of a tissue of the squamo-columnar junction, and you can see that this side you see your squamous cells, and there you have the basal layer, and then they mature up. And then right here, there's an abrupt change of cells. They go from the squamous cells to the columnar cells. And they always want to get a smear of this transformation zone because, you know, squamous cells are for protection. So the squamous cells do good protecting against viruses and stuff, but what happens is when you get these glandular cells, that their job is not to protect. So a lot of the cancers start at the squamo-columnar junction. This is a normal squamous tissue, and you know, to me, it's kind of like a building block, and that's the way the tissue has to be, you know, built up. You have the basement membrane, and as these cells mature, and of course, we know that hormones like estrogen cause these tissues to mature. You end up with the flat squamous cells. So we're going to talk about two types of cells. The body has many, many types of cells. Every organ has a different kind of cell, just about. A liver cell looks different than a cell from, say, the lung, or you know. So, but we're going to talk about these two types of cells that we see in Pap smears. One is called a squamous cell, and it's flat. To me, it reminds me of a fried egg, and the nucleus is, of course, the yellow part, and the cytoplasm is the white part. And this is about the ratio. It's called the nuclear to cytoplasmic ratio that you should have in a normal intermediate squamous cell. And then you also have columnar cells, which have little cilia on them, which are little hair-like projections that they kind of wave around, and they keep the mucus from, you know, moving. And so they're called columnar cells because they're shaped like columns. So this is a picture of a two normal types of squamous cells. And the reason some are pink and some are blue, it has to do with the maturation of the cell. And you'll notice that the nucleus is a little smaller in the pink cells than it is in the blue. But you still kind of have that fried egg look. And so you want to remember this nuclear to cytoplasmic ratio, and because